another episode of the Gaslit Truth podcast. I am your host, therapist Jen, and here with my jet-lagged co-host,
Drteralyn. Hopefully I can make it through.
She's got, I think you got this today. You can do it.
Okay,
If
we'll
you
see.
kind of fall asleep, we'll just assume it's jet lag or
You guys just keep going
narcolepsy.
if I appear
just
to
keep
nod
chatting.
off over here. It's nothing against our guest because I've been waiting for this one.
Yeah, this one has been taken a while. Everybody that's listening, you stay through this whole episode because
Please.
it has been months and months and months and months in the making to get our guest on today.
So much of that is my fault.
No,
It is.
stop.
Oh no, I'm pretty sure the first one was piss poor planning on this girl's part right here when we canceled the first time. So let's make that clear. But we are here, guys. And before we get started and introduce our guest, we just want to remind everybody to make sure that you get on the socials and like, subscribe, give us some stars. We want 4. Don't give us 3 without an explanation. And make sure you send us a DM if you ever want to tell us some information about you or your gaslit stories. As people know, we have a lot of guests that come on here and share all their things. So please do us a favor, send us a message. And if you like to email, that's okay too. We are the Gaslit Truth Podcast at gmail.com. And I am going to hand this over to Dr. Terry so she can introduce our guest today.
All right, so today we have Dr. Steven Storage, and before I give the real intro, I just want to say my first intro to Dr. Steven Storage was on TikTok. So make sure you check out his TikTok, and I think he did something on ADHD, and I stitched it or duetted. I think I stitched it, and that one I think I'm going to take a little credit for a little bit of viral video for you on that one.
Oh,
what? Yes. Suddenly his viewership went right up. So,
yeah, right.
So anyway, it's true. It's
It
true.
is true. No,
Is that real? As I don't know about this.
Yes,
so,
it's
and
true.
I don't feel gaslit. No, it is true.
Yeah. It's totally true. Anyway, so when I did that with you, I had no idea who you were. I had no idea. You'd just come on the scene, and I love psychiatrists on TikTok, and I was like, Jen, we need to get a psychiatrist on here, and boom, here you were. And so that's how it started. So welcome, Dr. Steven Storage, and now I'm going to read the official bio for you all. Dr. Storage was raised in Southern California and is a proud father of 2 boys. He is a diplomat of the Medical Board of California for Physicians and Surgeons and a diplomat in both child, adolescent, as well as adult psychiatry for the American Board of Psychiatry and Neurology. He graduated from the University of California, Berkeley, magna cum laude, with a degree in molecular and cell biology, and earned his medical degree from the University of California, Los Angeles School of Medicine, where he served as class president for 2 years. He completed his general psychiatry residency at Stanford Hospital and Clinics and his child adolescent psychiatry fellowship at the University of Southern California, where he served as a chief fellow. What haven't you done? Anyway, so he's also published several peer-reviewed articles and given numerous presentations covering a variety of subjects, including neuroimaging of psychiatric disorders, effects of substance use on the brain, anxiety, and the effects of social media on mental health, and psychosomatic medicine. That's only part of it, but I'm just going to welcome you to the show from here. Thank you for being here. I don't know where you found the time to do all that. Like, man, okay. Well, welcome to the show.
I think you guys are equally busy.
Yeah, I mean, it's really funny when you put all the things, and I only read a portion of it here, so you guys check out Dr. Steven Storage. It's really interesting when you put so many things together and you look back at yourself and you're like, how did I get here? And so we want to learn about you. We want to learn about, because I will mention that Dr. Storage is also part of the Amen Clinics in Los Angeles. So Amen Clinics, if people don't know, is more, I'm going to use the word alternative because there was some controversy around the Amen Clinics for a while. And I want to talk about that. I want to talk about how you went from all of this and integrated into that. So I'm going to close my mouth now and hand it over to Dr. Steven Storage. Thank you for being here.
Yeah, thank you for the introduction. No, what's interesting is the last 3 years of my career, I've been with Amen Clinics, and I feel like I've learned more in those 3 years than I did in the summary of everything that you read.
Yes.
So I'm a psychiatrist who was generally unsatisfied with the practice of psychiatry. as it is generally practiced. Usually the methodology is, as you guys talk about on your podcast, people come in with symptoms. You look at the symptoms, you cross-reference them to this book, the DSM. If people meet a certain number of criteria, you give them a label, and then you pick your favorite medicine that is designed to treat that label. And there's a lot of pressure to see patients quickly. I think a lot of doctors out there are doing their best. Not all, I think some people don't have their heart in it, but for those that do, they may be trying to do their best. And yet it's so limiting, right? Like when that is your focus on how to practice psychiatry, it works enough of the time that it keeps psychiatry as an institution alive, but not enough to actually be useful. So at Amen Clinics, the concept is mental health is brain health, which is not like that revolutionary of a concept when you think about it. Like, where do mental health conditions come from? They come from the brain. So if someone says it's all in your head, yeah, they're right. And they might also be ignorant. So mental health is brain health. And the methodology at Amen Clinics is, first and foremost, we spend a ton of time with our patients, right? So like an intake at Amen Clinics is 2 hours face-to-face with a psychiatrist. And prior to that 2-hour intake, patients have another 2-hour intake with a historian who gets all the little facts together so that during the appointment with the psychiatrist, we can ask the deeper questions as opposed to all the fact gathering. In addition, patients will do psychological testing, and then they'll do a brain scan. It's called a SPECT scan, which stands for something really long, but I'll say it: single photon emission computed tomography. It is a blood flow scan, right?
Bless
so we're
you.
looking So we're looking at where blood is flowing in someone's brain, and blood flow is a proxy for activity level. So if we see areas of high blood flow, that means that's a hyperactive region of the brain. Low blood flow, that's a sleepy region. You take that information with everything else, and then you can have a really rich assessment. And I mean, we can get into it, but the number of patients I've seen who have been over-medicated, misdiagnosed, who come in, and really part of our intervention is to get them off that stuff and get them on a treatment plan. Oftentimes it's holistic. It could be medication sparing. I'm not anti-med. Every now and then, like if a medication makes sense and it's well thought out, okay. But over prescribing of meds is a huge problem in psychiatry.
Let's talk about that.
Let's.
Yes.
Yeah.
So that's an interesting point of view, because Jen and I have talked about this a lot as therapists. The majority of people that come into our practice are medicated. Anyways, historically they have been. Not so much anymore. Things are changing, and I think that's because of what they're learning about us, right? So, but historically, and working in the prison systems, like everyone was medicated there, 90% probably.
Foster care systems too.
Foster care,
Yep.
ridiculous, elderly, terrible, like menopausal women on the rise, all these things. But we've said, we're over medicated, and the pushback from just saying that is ridiculous. Like, people, no, they're not. More people need medication. And I'm like, but do they really? So I would love to hear a little bit more about why you said that statement and what that means to you, what you've seen in your practice, because I have a feeling that that has something to do with the switch from traditional practice to what you're doing now. Can you fill us in?
Yeah, absolutely. So first off, the statistics on psychotropic medications being prescribed are alarming. For 85% of psychotropic meds are prescribed by non-psychiatrists, right? So it's not just a psychiatry problem. It's also, there are
I'm glad you said that. I'm glad you said that, because people are constantly arguing that point, that it's, it's psychiatrists that are the ones prescribing, and actually it isn't.
Family docs, OBGYNs,
because there's more of them, right?
Right.
Just by the nature of how medical training is, as you get further and further and further on into subspecialties, there's fewer and fewer and fewer of those people. Yeah. So there are fewer psychiatrists out there than primary care doctors. And so primary care doctors end up prescribing, and OBGYNs, as you said, end up prescribing more of the psychotropics than psychiatrists do. So that's an issue. And when you actually analyze that prescribing, standard of care is only met 12% of the time.
Holy crap.
So that's a big issue. And then within psychiatry, again, when everything looks like a nail and you're a hammer, then suddenly the only tool you feel like you have is to prescribe medications, especially if you have these quick visits. And that's what I didn't like, right? That's what I didn't like. I didn't go to school to just think about what my favorite med is and how to match it to the right person. I became a psychiatrist because I care about people's stories. I want to get to know them as human beings. I want to really understand how to help shape their life in a way that gives them the best version of themselves. And so meds can sometimes be a part of that, but more often than not, what we're doing is we're thinking about some of the basics, right? We're thinking, is there anything medical that we're missing, right? We should get some labs done, right? We should make sure that this isn't a person who's hypothyroid and people are throwing antidepressants at them. Yeah, shocking, right? Rule out medical conditions first. Number 2, what does the lifestyle look like? 3 pillars to brain health: sleep, exercise, and nutrition. And it's tempting to try to go for a quick fix with a pill, but that pill is probably not going to be all that effective if the 3 pillars aren't up. So we spend a lot of time talking about that and engaging people in that. Mm-hmm. Supplementation, right? Supplements can be a really, really important part of maximizing brain health, especially if it's directed in, a rational way. Technology-based interventions, right? Like things like vagus nerve stimulators, neurofeedback. These things can be super powerful in shaping the brain. Therapies, obviously, right? That's where you guys come in. What's the modality? What's the way to match someone up with a therapist that they really connect with? And that's just the beginning, right? And then maybe you think about meds if someone is having really distressing symptoms, it's severe, and they're not making enough progress once you've built all that up. But that's the order it should be thought of, not like, here's a med.
Yeah, that med came very, very last in that list. Like that was like the very last little thing that you mentioned. And I think
Correct.
we have it completely backward right now. We are doing meds, people are feeling worse, there's side effects, and then we're trying to go on recon for these people, like what now, or get you off of these things, that might be making things worse. To me, it's a pretty sad state of affairs with mental health, the way it stands today.
Well, if you think about it from a business model, the best businesses are successful when they have repeat customers, right? True. And so how do you ensure a repeat customer within psychiatry? You prescribe an addictive medication, right? And I'm not sure that people are necessarily doing that nefariously, but I do think pharma has a hand in a lot of what our practices are and how insurance reimburses for things. And if you have someone who needs to see their psychiatrist every month to get their refill on whatever it is, that can be a successful business model, but it's not a good human model.
Yeah, you had said,
sorry.
Yeah, that was. I was gonna say, did you write down 1332?
Yeah, I did already.
Because that's going on a deliverable. That was an excellent line there. Everything cool you say, we keep notes on it here. It's very legit, and then it
very
goes
nice.
on a deliverable. Yeah, I mean this is really high functioning podcasting here. I had to ask you a question about something that you said at the very beginning, and I'm assuming it's going to tie into some of the things that you just rounded off saying. You said you were unsatisfied with the model of psychiatry. I didn't go into school to like try to put a med on somebody and match in that way, right? It was about something different for me. What did you experience prior or in the past? Maybe before, you said you've been with Amen for a few years now. What did you experience before that didn't fit with, what you believe within the model of psychiatry? What was it like?
Yeah. I've worked on inpatient settings. I've worked on consult settings. I've worked outpatient settings. And I don't love the idea of seeing someone over and over and over through a revolving door, right? Like longitudinal relationships in psychiatry are very important as long as someone's getting better. But on the inpatient side, for example, you could see someone come in and then you could see them come in 2 months later and it's the same thing going on. And then again, and the disconnect in their care is awful, right? The care gets so fragmented. Like they're seen by one person, they get started on this regimen, they go home, follow-up might not be great, they destabilize, they get readmitted, new medication regimen, they get discharged, bad follow-up. And it's just throwing darts, right? It's throwing darts and it's guessing ultimately. Psychiatry it's a lot of guesswork, right? I mean, some people might frame that as saying there's an art to practicing psychiatry, but we don't have to be too artistic, right? Like we can also be scientific. And that's where looking at the actual brain is helpful because there's less guesswork, right? Like if I look at someone's brain and I see, for example, they've been diagnosed with bipolar disorder, but the history doesn't quite fit. And then I look at their brain and I see, gosh, there's evidence of a really severe head injury here. And there's ADHD. Could that be what's contributing to the mood swings, right? And that's a very different treatment regimen. So why guess when we can do better?
Mhm.
Yeah.
Did you have like an epiphany moment that you began like searching for something alternative, or did I hate the word alternative because I feel like this should be
Yeah.
primary and all the rest is alternative, but we have it backward. But was there like an epiphany moment that you're like, I have got to find something new, or did it just kind of fall in your lap and you're like, this is eye opening. So what was that like for you, that little transition?
I've had jobs. I mentioned working on a consult service in the past where we would frequently interface with neurology, right? So neurology and psychiatry would both be seeing the same patient. And it seemed as though we were speaking different languages, which we really shouldn't be, right? We're
Right.
both working with the brain. And there'd be times where there'd be differences of opinion, and neurology would say it's psychiatric, psychiatry would say it's neurological. And I'm just like, guys, we should be on the same team here, right? Like it's both. We're talking about the brain, and the mind stems from the brain. So I think that ate away at me a little bit over time. And then I ended up finding Amen Clinics through a research project that I did when I was over at USC. I did a research project with a mentor on SPECT imaging to differentiate pediatric ADHD versus bipolar. And as part of that project, we utilized the Amen Clinic data set because they've got the largest neuroimaging data set in the world, 250,000 SPECT scans. And then from there, met Daniel Amen, hit it off. Our sort of philosophies very much aligned, and I've been happily a part of that family ever since.
So, what did he tell you that was so, or was it the spec scans themselves? Was that the like, holy crap, we can actually have some data here? Like, because otherwise, psychiatry and psychology are not driven in hard data points. They're driven in
Correct.
the checklist we talked about before and all of that stuff. And there's no hard data. Was that the appealing part? Like, this is hard data and it actually looks good, like the data is good. Because I know historically those spec scans came with a lot of controversy, early on. I've been following Dr. Amen for years before it was cool to follow Dr. Amen. So, but I also know that those spec scans in the early days of that, I would talk to people about it and they're like, that's just ludicrous. That's hocus pocus, all those
Hokum.
things. Hokum, yes.
Mhm.
Jen, do you remember that at all in the prison? Did you ever
Yes.
know about the specs? Yes,
Yes.
yes,
Yeah,
yes.
we
So
Yeah.
Jen
weren't
and I
we yeah.
we worked together years and years ago, but I remember looking at the spec scans and it was all very much like, no,
Yeah.
absolutely not.
It's
So
only a research tool. It can't be
Yes.
used for clinical practice. And
research.
yet here the technology is 30 years later with outcome measures being checked at Amen Clinics with some of the best outcome measures that you'll see. And I can say that confidently in my own patient population, right? Like I went from feeling as a psychiatrist, like you'd have wins every now and then, but
Yeah.
there was a sense of not being able to really enact all that much change. Whereas now I'm seeing such awesome outcomes with my patients, and it's tracked at Amen Clinics. So Amen Clinics sees patients who on average have seen 4 or 5 psychiatrists in the past, who on average have been on 4 or 5 medication trials in the past. And if they follow the recommendations and stick with the program, 80 to 85% report positive outcomes. So if you think about that in that population, that's pretty powerful. So you're right. Daniel Amen took a lot of criticism early on, and sometimes to this day, about SPECT scans not being a viable part of a treatment plan. But when you look at the actual data, when you look at how people are actually doing, it tells a very different story. And if we're saying that the gold standard is how psychiatry is practiced right now, we really need a different measuring stick.
Yes.
Oh boy. We love those words. Gold standard. That's like
Gold
our
standard.
favorite.
We just did a whole podcast on the gold standard.
Being trained in all the gold standard interventions that are missing all kinds of good things that people need, right? But that's what, what's given to us.
But what appealed to me, the reason I ended up joining, again, my philosophies align very much with Daniel Amen's, which is, number one, mental health is brain health, and that shouldn't be a revolutionary statement, and yet it seems
shouldn't.
to be.
I don't know why it's so controversial to even think that. Like, I don't get
Number
it.
two, within the medical practice, what other specialty doesn't look at the organ that they treat, right? I mean, if you went into a cardiologist and they're like, your diagnosis is chest pain, you'd be like, thank you so much, I knew that, but where's it coming from, right? So if you go into a psychiatrist, and they don't listen to your heart rate, if you go into a psychiatrist and they say, your diagnosis is depression, it's like, yeah, I knew, I understand, I'm depressed, but again, where's it coming from? And is an antidepressant going to be the right way to treat everyone's depression? No, that would be ludicrous. Just like giving nitroglycerin to every person that walks in with chest pain wouldn't be a smart move.
Right.
Yes. So this whole where's it coming from? Well, I want to back up because I say you don't go to the ER with a broken arm, a clear broken arm, and they give you a checklist to find out if your arm is broken. You know your arm is broken. You don't need a checklist to tell you, the symptomology of that. We are the only health professionals that only use reported symptoms. But the weirdest part to me is in today's world, and this might be driven by social media, so you might have some insight on this. People don't seem to, that's generalizing too much a little bit because some people don't seem to care or worry about where it's coming from. What they care about is getting the diagnoses. Like, I have ADHD. That's why. Or, oh, I have depression. That's why. Or anxiety. It's a lack of caring. Like, but why? Where did that come from? How can I fix it on a deeper level? How can I heal myself differently? And by the way, using the word heal, people just go crazy when I mention, that particular word. So do you find that in your practice that, well, I mean, I would also guess that you're like the last in line to receive many of these people because it's like, okay, I've tried everything and now I'm going to come to you, often. But it seems like in the mental health world, it's, here's your diagnosis, here's your medication, and that's it. It's just, well, it's because my brain is broken, or it's because I have bad genetics, or it's because and there's nothing I can do about it. And this is that forever patient client thing, So he's shaking his head. So you're not watching YouTube. You gotta, yes.
A big message that we tell patients, that I tell every patient I see, is you are not stuck with the brain that you have. And we can prove that, right? Scientifically, like you can have someone have a image of their brain, like a SPECT scan early on in their treatment course, and you can do a repeat later on. And you see changes, right? Blood flow is dynamic. Parts of the brain that are sleepy can perk up. Parts of the brain that are overactive can calm down. And that's oversimplifying it a little bit, but it's true, right? Brains can change. Our brains have the ability to change even into old age. So getting a diagnosis can be an important step, although diagnostic labels are fraught with problems. But I think understanding on a deeper sense, what is actually going on gives you the insight to be able to do something about it, right? And people are thirsty for knowledge. Like, we all want to understand ourselves. We all want to know why we might be suffering in the ways we're suffering. We might want to know what the associated strengths are with that suffering, right? And then ultimately, what do we do about it, right? That's the call to action. And that's where I think our clinic does a good job of really trying to motivate people, because when you see your brain and you see what it could look like, that's really, really motivating, right?
Yeah.
Really motivating.
I
Makes
would
one do
imagine. Yeah, I would imagine it. People like data. They like real data, and they like X-rays, and they like all of those things, which typically mental health does not give. What they would give is like a psychiatric evaluation, and then you're stuck with that for years. As being, this is your diagnosis, this is what it is forever. This is what. So I love the idea that you're not stuck with the brain that you have, which is also fascinating to me, because we've known about neuroplasticity forever and ever and ever and ever and ever. Amen.
I've been waiting for the amen in here so much.
Yeah,
Exactly.
come on. When are we going to drop that?
Yeah, I know. Like, come on, this
It
has
just
to
felt
happen.
right. It felt right. It just came out.
You're
But
getting
no,
all preachy.
but
It felt supernatural in that moment. Yeah.
yes, it did. But I do think about that, because we talk about neuroplasticity. I mean, I used to work in a head injury rehab center years and years ago, and would watch people come in who were nearly barely functioning and walk out walking and talking, like.
Yes.
And so that was in my 20s, and I'm forever grateful to have witnessed that, to know that the brain can make new connections and change, and all these things. But in the mental health world, it's like, nope, except for mental health. Like, once you have that, your brain will not change. It as a forever sentence for you. I'm like, but
Brains
what
can
about,
change.
yeah, what
Yeah.
about
Brains can
neuroplasticity?
change. Exactly.
Brains can change.
Especially if you put the brain in the right environment to change, right? I mean,
Mm.
if you've got someone who, just hypothetically, has depression because of a history of childhood trauma, they're exposing their brain to all sorts of substances, using a lot of cannabis, alcohol, not really engaging in any sort of work around trying to heal their brain, maybe taking an antidepressant. The prognosis on that doesn't look great, right? But if you have them dive into the trauma work, do some EMDR, change up their lifestyle, get sober, suddenly the brain is in an environment where it can thrive and make new connections, and depression could be something in the past, right? The goal in working with patients is remission, right? So you said healing, I'll say remission, right? That's
Sure.
the goal.
Right.
It's not just learning how to live with depression, maybe for a while, but the goal is remission.
Right.
Yes.
Yeah. And you said substances, like you mentioned cannabis and alcohol. I'm curious to know your take on utilizing these types of methodologies, whether it's a SPECT scan or some of these other, um, you know, approaches that you offer specifically for addiction. And I'm not, and I don't, I mean, it's a very general question, but what do you see for patients that come in that are really struggling with addiction and the outcomes with this?
Yeah. So and when we say addiction, it's not just chemical, right? I mean, it's behavioral addictions. In kids, it could be video games. In
Yep.
adults, it could be
Does it all look the same on the
sexual.
SPECT scan? I'm
It
curious.
all looks
Oh, okay.
very
It
similar on a
does.
SPECT scan.
Oh,
So
what do you
basically,
know?
what you see is there's a region within the brain known as the basal ganglia. It's a very deep structure, and within the basal ganglia, there's a little part of it called the nucleus accumbens. Its job is to release dopamine whenever we do something that feels good.
Yeah.
The problem is the more we do that thing, the less dopamine gets released, right? So I call it the lemon squeezer problem. Initially, a lot of juice. Later, you're white knuckling it and you're getting drops. As that happens, the basal ganglia essentially says, hey, what gives? Where did all the dopamine go? And it ramps itself up in activity. And so on a SPECT scan, you tend to see very, quote unquote, hot basal ganglia, very active basal ganglia. And that's associated with stress, anxiety, overwhelm. So guess what happens to the addicted person? When they're not engaging in the addiction, that stress, anxiety, and overwhelm is even higher than it ever was. And so they feel like they need to go back to the very thing that is causing them to go down this downward spiral. It's amazing that you can talk about that all day, right? It makes sense. But when someone sees that actually happening to their brain and they see neurocircuitry getting hijacked, and if it's a chemical addiction, they see evidence of like an unhealthy cortex, right? Like it can sometimes look like holes on a SPECT scan, not literal holes, but areas where blood flow is so low and activity is so low. It's a wake-up call, right? It's a wake-up call, and it becomes much harder to engage in denial when it's right there in front of your face.
Yeah.
100%.
Yeah, I was kind of having a flashback, a bit of a flashback when you were talking to some like the functional medicine, just labs that I've done, nothing like a SPECT scan, but when you see the results in front of you, it's one of those things where it's just like, okay, for years and years, I've had, providers tell me this or this, and then you do some of these labs and you do some of this functional work and you look at it and it's a very different,
crap.
I read a report and just like cried and cried and cried as a patient going, oh my gosh, this means something now. And I've never gotten to see it in this form before. The form it's been received in is, well, Jen, you have depression, or Jen, you have anxiety, or, and there was never anything more than that. Maybe some blood work here or there just to make sure that the meds I'm taking aren't jacking up my blood pressure. But, other than that, you never get to see that part. And I think there's something very healing and real about that.
Empowering.
It's very empowering. And you just go back to it over and over and you look at it and it's like, okay, this, and then so I want to know too, I'm just asking about the addiction piece then. The area of the brain that you're discussing with addiction, right? Tell us a little bit about what you see when you have patients that are coming in that have been on psychiatric medications.
Thank you.
For significant amount. I was going to say significant amounts of time, but I also know that not to be true either, because you can have somebody who is 20 years or 2 years, and it's still going to be impactful. So, can you talk about what that looks like and what you see?
I'll tell you a specific story. So,
excellent.
We saw a patient who was adult female in her 40s who had been diagnosed with schizophrenia in her late 20s. That diagnosis, by the way, was questionable. She was experiencing symptoms that largely could also be attributed to post-traumatic stress disorder. However, she was placed on antipsychotics and eventually was placed on an antipsychotic known as clozapine. Clozapine is, of all the antipsychotics, by far the most effective when you look at research studies. However, it has a really, really nasty side effect profile. And her scan looked terrible. Okay, her scan looked absolutely terrible. It looked like a demented brain, the same that we would see in someone with Alzheimer's dementia. And she hadn't had any psychotic symptoms for years and years and years, over 10 years. Okay. And so each time she'd see her psychiatrist, the psychiatrist would say, well, you're not having psychotic symptoms, so that means the clozapine is working.
Must be working.
And we should continue it, right? We should keep going. It doesn't seem to be causing any harm until you actually look at her brain and you see that it is causing harm, right? And that psychiatrist was very resistant to the idea that maybe we should try a lower dose, right? Like maybe we should just lower the dose a little bit and see. And eventually they allowed that to happen and the patient did great, right? There was no resurgence of psychotic symptoms, less sedated, less dry eyes, less dry mouth, better cognitive functioning, able to actually have a conversation as opposed to being, totally numbed out. And that's one example. So certain meds can have deleterious effects on the brain and on a SPECT scan. So classic examples, meds that are really sedating, benzodiazepines, big one. I try very, very hard. If people are coming in on benzos, I'm trying really, really hard to get them off of benzos because it's associated with risk of Alzheimer's dementia. They're highly addictive. They lose their efficacy over time. They're just a very nasty medication class. Opiates, same thing, very, very much the same thing.
Yeah. Yeah.
What
So
about your typical SSRIs or SNRIs? Would or even I'm just going to go down to stimulants, like the big three. I'm sure that you see the majority of people coming in on, because that's what the majority of people are being prescribed. How does that change the brain?
Well, with stimulants, the main way that they're working is they're ramping up norepinephrine and dopamine level, right, which can help fuel the prefrontal cortex in the right patient. What I see very often is there are people who have been diagnosed as ADHD who actually don't have classic ADHD, right? Their ADHD is not coming from a prefrontal cortex that is sleepy. It's coming from, to oversimplify again, an emotional brain that's very active. So you put them on a stimulant, what are you really doing? You're ramping up a prefrontal cortex that's already doing okay, but you're also ramping everything else up. If anyone took a stimulant, they'd probably be able to focus just a little bit better, right?
That's what I keep saying. I'm like, of course,
makes sense.
menopausal women are getting on stimulants like crazy right now. And I'm like, and they're like, and I feel so much better. I'm like, of course you do.
Yeah.
Of course. I would clean the house a lot more, probably. Yeah.
So if it's the right patient and the right fit, it could make sense. But if it's the wrong patient and the wrong fit, then you got to go a different direction, and I see that all the time. Same with SSRIs. I've got probably the most common scenario we see is someone who's coming in with past diagnoses of depression, anxiety, and ADHD, right? That trifecta. And many of them are coming in on SSRIs. But guess what? SSRIs in some patients makes ADHD worse. Serotonin and dopamine are in a seesaw relationship in the brain. If you ramp up serotonin with an SSRI, you drop dopamine level. And for someone with ADHD, that can be a problem. So now maybe the symptom of anxiety and depression is down, but perhaps the root cause, in many cases, ADHD, is worse than it was before. And the person feels stressed out because they can't get stuff done. They feel bad about themselves. Their self-confidence drops. They fail at work. They fail in relationships. And
they're failing
they're a
at
little
meds.
numbed out because of the SSRI.
And they're failing, I'm air quoting that, at medication, right? Like you're resistant to meds. Like we say a lot of things like that to our clients. So, okay, I want to talk about ADHD for a second, because I know on TikTok you talk about it quite a bit. So if I'm correctly hearing you, basically people need to get this type of scan in order to know if they have ADHD, number one, or what kind of ADHD they might have, right? Because otherwise, again, it's a cascade of checklist symptoms, right? And then medication seems to be the way to resolve that, especially in our kiddos, right? So I just want to talk about this a little more, because I'm pretty impassioned about the whole ADHD thing in kids, because I'm very upset about it at this point, because I think it's one of those things that is highly overdone. Primarily because a lot of people are saying, well, it's a neurological condition, you're born with it, and I always go, well, then prove that before you medicate. Prove it. Why would you just medicate something like this without proof?
Right. Yeah.
So go ahead.
And there's danger in misdiagnosis of ADHD, for sure, especially in young kids, and kids who are getting diagnosed at a really young age too. There is a range of neurotypical, quote unquote, I don't love that description either, but neurotypical behavior. And you can have someone on the high end of that who doesn't necessarily display distress or challenges with functioning around that presentation, right? So for me, the best way to diagnose ADHD is to not rely on any one thing, right? So a history by itself is not sufficient, because is the kid hyperactive and, let's take it to an extreme, disruptive, unable to control themselves, unable to sit down in a classroom, can't learn, their developmental trajectory is affected because of that, relationships are damaged. Is that because of ADHD? Is it because they've been through traumatic experiences and this is how their trauma is manifesting? Is it depression? Could they be on the spectrum? Right? There's so many different explanations for the symptom of hyperactivity. So going off symptom checklists isn't going to do it. Neuropsych testing can be helpful, right? We do some neuropsych testing in the office. But again, you don't want to rely exclusively on that, because what if someone's having a bad day? What if someone's actually really into the testing, like they like it and they're engaged in it, but they're not engaged in the classroom, right? So then they perform very differently in
They
one
do
setting.
very well. Yeah. You're like, I'm not
they
seeing
do.
any inattention
2
at
hours
all.
of testing and they're fine. Like, this is
Yes,
great.
because maybe the testing feels
Yes.
like a video game. Maybe it feels
Maybe.
like it's a competitive
Yes.
thing. Maybe it's
Maybe they got a
novel.
good relationship with the tester, like, you
Yeah,
know, all
yeah,
these things.
exactly.
Yeah.
And then the way a scan comes in is you will see neurobiological evidence, right? So if someone has a scan done and there are holes in their prefrontal cortex, that's a pretty good bet that they've got classic ADHD. And if they don't have that, they might have a different type, right? They might have a different type. So one of the most common types that I see in young kids is something that Daniel Amen coined as the ring of fire type of ADHD, which is very provocative, right? But essentially, when you look at their deep emotional brain, instead of being this calm blue color, which is indicative of baseline blood flow, everything's red and white, which is indicative of medium to very, very high blood flow. And so those brains are just racing, right?
Oh, yeah.
And you put a stimulant in that mix, it can be like lighter fluid in a wildfire, right? So instead, we think about things like supplementation, maybe using a mix of GABA, 5-HTP, L-tyrosine, magnesium. It depends on the person, but you can see really good results. And often dietary changes in pediatric ADHD. I saw someone just on Friday, actually, who's 80% better per their report based on just changing their diet and adding in a handful of supplements, right?
Do you get because we've seen that too, in
I
just
believe it.
all the time, just changing. I tell people, like, get a 70% in the assignment and you're going to feel better. Like, you don't have to do 100% all in, but just get a 70, a nice solid C, and you're going to start feeling better, which will be motivating for you to do a little bit more. But again, there is this pushback idea of, how dare you think that nutrition is going to help somebody's mental health?
Oh gosh, that feels a little bit triggering.
It
Yeah.
does. Tell us about that trigger.
Especially in America, where we have a food industry that is absolutely broken. I don't know how much time we want to spend on this, but I could spend an hour.
We might need a part 2. We'll do a
we
part
may
2.
need a
Yeah,
part
we may
two.
need a
We
part 2.
may need a part two.
Yeah.
I tell people, right, McDonald's French fries, just as an example. How many ingredients are in McDonald's French fries in the US? 19 is the answer. 19 ingredients, right? Should be
No
3,
idea.
right? Should be 3. Should be
Yeah.
potatoes, salt, oil. It's 19. It includes things like natural beef flavor. So McDonald's French fries, and that has gluten in it. That has beef, in it. So McDonald's French fries are not vegan or gluten-free. They add sugar to it to make it more addictive. There's an ingredient in there that's also used to make silly putty. I mean, this is what is fed to us, right? And processed foods are associated with increasing inflammation in the brain. There was a study out of Harvard last year that looked at over 30,000 women, tracked them for 14 years, and nobody at the beginning met criteria, quote unquote, for depression. Okay, it was an exclusion criteria. By the end of the study, lots and lots of people had depression. And the women that had the highest level of processed food, the top 20%, had a 50% higher rate of developing depression. And they controlled for other variables. They controlled for socioeconomic status. They controlled for substance use. They controlled for all these other factors. It was the processed food. Processed food ramps up inflammation. Inflammation is bad for the brain, right?
Yes.
Refined sugar, same deal. Gluten, especially in the US, right? Just because of how gluten's been raised for a very long time. These things have powerful impacts on brain health. And when people get that right, it's one of those 3 pillars, right? I mean, it may not be the final answer, right? You got to get the other pillars up too: sleep hygiene, exercise, avoiding things that are bad for your brain. But it's huge. Okay, it's huge.
It's huge, and one of the most dismissed things.
Yeah. we were just talking about this. Several addiction clients, right, that we're doing some functional, medicine with, and that's just a piece, right, of the treatment plan, right? The rest of it is you talk about 3 pillars. We have our 4: eat, sleep, move, meditate, right? So we've got a fourth,
Mhm.
which is our our meditate one on there. And we were just saying this the other day. Nutrition is non-negotiable. Like, it is one of, not that one is more important than the other, because they're all very important, but this idea of nutrition, especially within the concept of, we're doing a lot of addiction work, right? How non-negotiable that one is, and that is very hard for people.
Mhm.
Like, that is the most difficult. Like, people are going to go, yep, Jen, I'll learn yoga. We're going to do all this meditative practicing, right? Mindfulness, like up the wazoo. Yep, that's great. And I will nurture sleep. My sleep hygiene is going to just be top freaking notch, right? Great. Like, we'll do all these things, exercise and movement. Sure, I'll start moving my body. But when you hit that nutrition pillar, what are you putting in your mouth? It
Yeah.
is just the hardest thing for people to try to make even small changes in, because of the addiction that lies within the food and the beverages that
Well,
comes,
it reminds me of a rat study that maybe you guys are familiar with that was done a while back. But basically, they took rats, right? And we're different than rats, but we're both mammals.
Yes.
And so they took rats and
Rats are cheaper to research on than
yeah,
humans, but
it's much easier to get through
a bunch of rats.
investigational review boards with
Yes.
rats than
It
humans.
is.
Yes,
I
for
could
sure.
imagine. Yep.
But they took a bunch of rats and they gave the rats a choice, right? Either water that was infused with sugar or water that was infused with cocaine. And they also controlled to make sure that they tasted similar, right? So that it wasn't just a taste thing.
Yeah.
The rats went to the sugar.
Mhm.
That's what they got more addicted to over cocaine. So the conclusion of that study was sugar has the potential to be more addictive than cocaine. And I totally see that in my
People
patients.
hate that. People
They don't.
hate
Yeah, they
saying
don't hear
that.
it. They don't want to hear it.
They don't
Yeah.
wanna they don't wanna see that. They
It's
don't
just
wanna
the
hear
hardest
that. They
thing.
don't wanna believe that. Yeah, and it
But it's true. Think about how people talk about sugar. I need my sugar. I'm having a sugar craving. Don't take away my sugar, right? I mean,
Yes.
Mhm.
substitute sugar for cocaine.
You
And
can.
Don't say that.
no, don't substitute sugar for cocaine. But what I mean is,
He went, "Wait a
in
minute."
I don't know where this is
take
going right now.
phrases, take those phrases, right? Take those phrases and
Yeah.
swap out the word sugar for
Swap
the
it
word
out.
cocaine.
Right.
And that's what I mean. Do not use cocaine. That is not what this
That's not the
psychiatrist
message.
is
Oh, yeah, like, this one took a really big turn. We might have
Uh,
to do some editing in this episode, because I don't know if we say a lot of crazy shit, like, on the show, but I don't know if we could let that one's probably not gonna fly.
To be clear, I am not advocating for
Yeah,
the use of
he's like, we're
cocaine.
gonna run a disclaimer around the bottom of this one just so people know. That's funny. No,
I'm waiting
we
for Terry
understand.
I am
to
Steven
say
Storage.
something
I
like
do
that.
not approve of cocaine use. Okay,
No,
people.
no, no, no. I think getting back to the nutritional conversation, I think so much of it has to do with diet culture, and because we look at food in this way, like no food is bad food, and you'll see this on social media with dietitians and things like that. No food is bad food. If you want to lose weight, it's calorie deficit. We only look at nutrition when we're in weight loss. Like in the weight loss thing, people don't associate nutrition quite yet, most people, with mental health. And particularly with ADHD or a kid's performance at school or any of those things, like it is off the table. Unless it is about, and Jen and I run into this too. Like people come into our office and what are your goals? What are your goals around nutrition? Weight loss. Okay. You're
Mhm.
coming to a mental health therapist and you're going to be like, I want to lose weight. I'm like, you
Yeah.
know, but then you
Yeah.
ask them to add in certain things or maybe take a look at taking, I don't know, alcohol out of your diet before you go to bed, for better sleep. And it's like, well, when can I drink the alcohol then if I can't before bed? Like how many hours is too close to bedtime for that? Like this
Yes. The
negotiation.
negotiations
It
Yes,
begin.
is.
Yeah.
the
It is.
Well,
negotiations begin. Yeah.
the brain consumes roughly 25% of the calories we eat, right?
Oh.
So when you think about that, food is medicine, right? Food is medicine. And our mantra is love food that loves you back, right? And it doesn't take a genius to look at a food and say, does that food love my brain back? If we were to play that game, right? Alcohol, the answer is no, right? Of course not. Imagine pouring some alcohol on top of a soft, buttery brain, right? Not a good image, right? Refined sugar, is that loving your brain back? No, right? Processed food, is that? No. Whole fruits and vegetables, yeah, sure. Lean proteins, complex carbs, healthy fats, fantastic. But ultimately, what we put in our body, 25% of that is fueling our brain. And our brains are so miraculous, right? Like, we try to get people to understand that the brain is more complicated than the universe itself. Right? When you think about it, there's more connections in the brain than stars in the universe, right? Which is crazy. There's 100 billion stars in our galaxy. It's one of 100 billion galaxies. Multiply those numbers together, we've got even more going on in our head. And so do we really want to be bathing that in crap, or do we want to be feeding it what it really wants?
Yeah, it's like the most important organ of the body that we don't nurture. Like, this is something Terry has said before when I was learning all the brain health things, right, from standard traditional therapy, which is, psychotherapy, right, which is what all I did for so long until I started to jump into this realm. And it's such a powerful thing to think about. We're not taught to nurture that. Shit, in school, we're not taught to help clients nurture that. That isn't a thing. At all, actually, Stephen, when I'm like talking about this out loud, like when you think of all the education that you have had and what you have done, how much of that revolved around the brain and nurturing it, not what site does. 2 hours. There
2
you go.
hours.
The answer is 2 hours. In medical school, you get 2 hours of didactics around nutrition, lifestyle modifications, these sorts of things. 2 hours out of a 4-year curriculum. That is because, again, the Western model of psychiatry is reactionary, right? You're coming in with a disease, here's the pill, as opposed to preventative. And when you focus on lifestyle, the conversation shifts. It's preventative. Right?
Yeah.
Mm-hmm. Do you want to know how many hours I got?
Is it less than 2?
It's less than 2. So it's like everything you learn about later, and you kind of mentioned this in the beginning, like it was like, forget about all that really cool education that I have. The most important stuff happened over here. And I think Jen and I are at this place where the same zone. Like, forget about all of that. The most important stuff happened over here, where we sought out, how to do nutrition or incorporate pillars of functional medicine and things like that. Like, that's where the most important work is done, not in just diagnosing and labeling people and telling them they have thinking errors or throwing a medication on top of something. It's all the other stuff. And I really wish more mental health professionals of all levels would seek that knowledge out. I think we would be a better mental health world if that would happen.
I hope the same.
I feel like that's a really good ending, but I still have like one more question. And we have a few minutes left, but you just really wrapped it so pretty there. But I still have one more question, so too bad.
Okay.
Stephen, can you tell us a little bit if you are you somebody who has ever had to be at the other end of resistance, whether it's from like patients or whether it's from colleagues that just can't seem to buy into this new age model that isn't really new age at all? Do you get a lot of resistance within your field, even amongst
how do you handle it? Yeah.
Absolutely. From patients, not so much, because and some of that is selection bias, right? The patients I'm seeing are choosing to come to see me, and they are
know what they're
on
getting
board with the methodology and have bought into that on some level. Not always, though. I mean, some people we see don't totally know what we do until they get there, and still have good outcomes. But I have plenty of colleagues and friends from medical school, including ones that I play fantasy football with to this very day, and they may sometimes throw barbs or say things that would indicate that they're not supportive of this type of methodology. And frankly, I don't blame them because I don't think they know any better. And that's not me being, pedantic. Like
Yeah.
the way that you get trained up
Yeah.
in medical school and residency and fellowship is you've got a dogma being pushed on you.
Mhm.
And it's almost like blinders, right? That's
Mhm.
all you can see. And if something is outside of that, it takes someone who's willing to take a risk. It takes someone flexible. It takes someone who's fed up with the standard of care to be able to go out on that limb and then experience it and see if it actually works, right?
Yeah.
But if not, you're stuck in the dogma. And we need to get people out of the dogma because it's not working.
No, this is once you know something, you can't unlearn it. Once you are enlightened by something, like you even go to a conference on nutrition and mental health, just a small little conference, and you're like, you either go, "What is this?" or you go, "Whatever,"
Woo woo. It's woo woo.
It's woo woo, it's whatever. But once you get into that space where you're like, "What is this?" and you crave more, like there's something to this. But it does take someone who's willing to
Yes.
step out of the dogma and step out of the confirmation bias, step out of all of those messages that we
Mhm.
get, and be open to a new message, right?
Yep.
And be open to learning more about it and more about it. And I say this to Jen all the time. I'm like, don't just listen to me, Jen. Go out
Yeah,
there
she does.
and listen to other
Don't
people.
don't
Like,
listen to me.
don't just listen to me. Like,
Yeah.
I'm like, you have to listen to many people so that you can even formulate your new truth
Yeah.
within the new ideas that are coming to you. And I do believe more and more people are starting to
I think
have
so.
this enlightenment awareness, because I think they have to.
Yeah.
Because as the statistics are looking poorer and poorer for people, you have to wonder, am I contributing to that?
Yeah.
Is lack of something new the contribution to the declining of mental health in the United States?
And
So
ultimately, speaking of listening, are we listening to what our patients are saying?
Yeah.
Right.
no.
And the answer is no. And we need to. We need to do a better job as an institution.
Yes. Were there any final thoughts that you'd like to share before we sign off today?
I'm just so thankful to be on. I'm glad it finally worked out. We
Us
tried
too.
and tried again, and it's been really, really good talking to you guys.
Good. It was a
No.
great conversation. We'll have part 2, and hopefully it won't take as much effort to get you on for part 2 later on.
Yeah, we gotta get our shit together on this end because we're
Yes.
canceling all the time because we're just so important. So we gotta go do all of our big endorsement
Right.
deals and
Exactly.
all these big
Exactly.
things that we do.
Right.
No.
Yeah.
All right. So if you've hung out with us this far, please hit that like button, follow us, and send us a comment, and reach out by email at thegaslittruthpodcast@gmail.com. That is a wrap with Dr. Steven Storage, and we will talk to you all soon.
Thanks, everybody.